So I'd like to start this webinar off by introducing Dr. Siegrid Yu. So Dr. Yu is a dermatologic surgeon at UCSF, and she will be talking to us about Mohs surgery.
Thank you for that introduction. It's a pleasure to be here today. I was asked to share about skin cancer, but more specifically about Mohs micrographic surgery. So you'll see that my focus will be on that form of treatment. There are many treatment options for skin cancer, and I will be discussing the area of my expertise, Mohs micrographic surgery. So I just wanted to start with a brief introduction with regards to the surgical treatment of skin cancer, and specifically with Mohs micrographic surgery. The two main goals are, of course, complete surgical removal of the skin cancer, as well as minimizing the amount of normal tissue that is removed. And by doing that, it allows for functional preservation as much as possible of important skin and underlying structures, as well as addressing aesthetic concerns that patients may have. The fact that the margins are controlled microscopically in real time is really the critical point that allows us to offer the highest cure rate for those who are surgical candidates. Briefly, in the next couple minutes, I'll go over the technique. So this is a schematic of what a standard excision looks like. Skin cancer is there in the middle. The red lines indicate what a surgical margin and surgical excision may look like. Typically, in standard surgical excision, the specimen is then sent to the pathologist. What we call vertical sections are performed, and then the pathologist examines the margins. Now, with this way, there could be a margin of error, as you can see, if the section doesn't include those finger-like projections at the edge. With Mohs surgery, the margins are done completely differently, and we end up looking at things horizontally. So we're now examining a complete peripheral and deep margin, and this looks at 100% of the surgical margins. This technique was developed in the 1930s by a physician named Fred Mohs. He had a kind of an antiquated technique where zinc chloride was applied for patients. They would need to sit for 24 hours for processing and return to the office the following day for additional surgery. At that time, Mohs surgery did not include reconstruction, and everything was allowed to heal on its own. In his cohort of patients often healed very well with excellent results. This technique was kind of reinvented or revised in the 1970s here at UCSF with Ted Tromovich and Sam Stegman. And this is what we do today across the country. It's a modified technique where we use fresh tissue, but it's frozen in the lab. And so slides are created and turned around in about 20 minutes. So we can do multiple stages in a single day, making sure patients have clear margins, and then we perform immediate surgical reconstruction. So schematics of what this might look like. We start with a little bit of scraping to help assist the surgeon determine those peripheral and deep margins. We make an incision, and there are a lot of things that we do to ensure the clear orientation of this piece of skin. The specimen is removed with surgical instruments. We draw very carefully. We mark with ink. We mark with hash marks and stop any bleeding. The patient has a dressing, and there's a bit of a waiting period while the tissue is processed, and we review the margins. A careful map is also detailed. Sometimes when we do bigger specimens, tissue may need to be divided and inked. So here we have a diagram of what this looks like on a drawing. The edges of the skin cancer are removed. In this situation, it's divided in half and color-coded and submitted to our histotechs. If there's anything that we see that is positive, it's marked very carefully and oriented. The patient then returns for a second stage or second round of what we're doing. If the patient's margins are clear, then we proceed with stitching. So again, If the patient's margins here are positive, we indicate typically in red where we need to go. It's very precise, and we know exactly if we need to go wide or deep and in what orientation. Additional tissue is removed and the patient waits again. So here we have a patient. You can tell with the purple dots, this is the surgical impression of how far the margins may go. But it's sometimes really difficult to determine just by visualization or even with magnification, which I typically use. So that is another reason it's nice to use this real-time micrographic surgery to determine the true margins without taking too much extra. So you can see a curettage scraping is performed, the surgical incision is made all the way around. It's divided, and this is removed from the patient carefully. There's a little bit of cautery for stopping the bleeding. And this is how we process through the lab with diagrams and inking. And the frozen sections in the lab are then put onto glass slides, stained, and reviewed under the microscope. Now, what situations are best for Mohs surgery? So we typically reserve this technique for higher risk tumors, and I'll go over what some of that means. Recurrent or incompletely excised tumors, skin cancers with slightly more aggressive growth pattern, such as those listed here, infiltrative, morpheoform, micronodular, or anything that involves nerves or blood vessels, or any ones that are poorly defined. And this diagram here is, in this day and age, there's an app for everything. So there's actually an app where the healthcare provider can indicate the type of skin cancer, the location on the body, the size, some patient characteristics, like if there's any immunosuppression or not, if the tumor is primary or never been treated or recurrent. And it gives us a score. And if the score is anywhere between 7 and 9, Mohs is definitely appropriate. In the center, Mohs may be considered, and there's certainly some that score quite low, in which case alternatives might be more appropriate. So higher risk zones are in the purple here around the face. You can see this patient with a medium-sized basal cell carcinoma near the eyelid. Of course, we want to treat this appropriately and minimize any long-term problems, but we also want to spare that sensitive tissue around an important structure such as the eyelid and the eye. Other functionally sensitive areas are listed here, genitals, hands and feet, as well as fingers, and larger skin cancer size. We also like to do Mohs surgery for any patients that have immunosuppression due to medicines that they be taking or other reasons, and also patients who have some genetic predispositions for skin cancer. You can see how this patient here presented with growth there on the forehead, and the margins were quite a bit bigger. So it was important to figure that out. I was asked to talk about when Mohs may not be appropriate or feasible. And in this situation, oftentimes it's tumors that don't grow contiguously. So there are some skip areas. We wouldn't be able to pick that up on Mohs surgery, such as this patient on the scalp that has probably a spread of his cancer. Tumors that are too large because it takes a long time to process these specimens, or perhaps ones that have unfortunately gone too deep, or if the patient is unable to tolerate the procedure under local anesthesia. All of our procedures in dermatology and Mohs surgery in particular are under local anesthesia. Here is a list of the typical skin cancers that are managed by Mohs surgery. Most commonly by far is basal cell carcinoma. That is the most common skin cancer in the United States, followed by squamous cell carcinoma and melanoma in situ. It's important to note the very early stages of melanoma can be treated with Mohs. However, the deeper invasive melanomas, there are other gold standard treatments. And I've listed some of the more rare skin cancers that you may hear about, also treatable by Mohs surgery: dermatofibrosarcoma protuberans, extramammary Paget's disease, microcystic adnexocarcinoma, sebaceous carcinoma, and atypical fibroxanthoma. So I included this photograph just to indicate that even though something might look quite small, with careful examination on the microscope and chasing out the tumor, this has actually spread a bit. So sometimes what we see is what we get, but sometimes what we see is just the tip of the iceberg, so to speak. And it's important to be sure that we get all the margins before we embark on any kind of reconstruction. For the sake of time, I might just move forward and talk about multidisciplinary management. In our department, we definitely work hand in hand with our colleagues in head and neck surgery, plastic surgery, radiation oncology, and medical oncology in patients who are more complicated or have more challenging or recurrent skin cancers that require multiple different modalities of management. So part of what we do in Mohs surgery is also to coordinate and discuss with our colleagues in other specialties how best to jointly manage our patients. Here in this photo, there's a gentleman who on the surface does not have a very prominent or notable skin cancer, but with the Mohs technique, we were able to discover that he had some nerve involvement that just tracked underneath his skin. And so his excision was significantly larger. And we ended up involving our head and neck colleagues and our radiation oncology colleagues to help treat his skin cancer. Mohs surgery is recently a board certification. This was confirmed 2 years ago. So what is a board certified Mohs surgeon? This is typically a dermatologist who has done additional training in micrographic surgery and reconstruction and is proficient in managing both mild cases and typical cases, but also importantly, the management and identification of complex cases. So just a few words to end with reconstruction. I'll give you a few examples. And this is mainly to indicate the point that, skin cancers often arise in chronically sun-exposed areas. And typically where I work the most often is on the face. And of course, we want to, number one, have the goal of skin cancer removal, but just up there as just as important, we want to preserve function and also minimize any potential scarring, which is inevitable, but oftentimes we can minimize that. So in these next few slides, I just show some examples of small skin cancers with some stitching and in some cases, partial stitching with partial healing on its own. So Mother Nature does do a great job in restoring near normal appearing wounds. This is a design in which the Mohs surgeon looks at normal anatomic structures, and in this case is able to put in this situation, put the eyebrow back together and hide the incisions. Typically, we are also looking at nearby structures. In this case, I was able to kind of pull that circle of skin that was removed back into the sideburn and hide the stitching. Sometimes we work in areas that move around a lot and are a little bit more noticeable. But as you can see, with time, things really can heal well. And I often tell patients, if you have a significant surgery and a lot of stitching in the immediate period, please focus on careful wound care, following instructions, and try not to worry too much about how it looks in the immediate period, because things continue to improve many, many months and up to a year after the procedure. So you can see very noticeable incision lines and suture lines. And in follow-up, she unfortunately is here for another skin cancer there on her nose, but you can see how well her lip has healed. Even stitching on very prominent areas such as the nose, we have some tricks up our sleeve for pulling skin together, not necessarily in a straight line, but in ways to kind of optimize the normal contour of the nose and function. So healing over time is what we encourage patients to think about. And here's just another example of a patient, again, stitching in a very prominent position, but healing well over time. I think that's my last slide. Thank you so much.